you very much for that introduction. You'll be pleased to know this is a much more simple talk than things you've heard before. So I work in the NHS, which I'm sure you're aware has significant financial constraints. So this is all about how to improve the care of my patients and how we can introduce the fantastic new advances in science to directly improve the care without costing any more money, which is a massive challenge. So that's really where I'm coming from. So what I'm going to try and argue today, this afternoon, is that the problem with trying to look after patients is when we're taking it as basic clinical history, free thing to do, doesn't cost you any money, is that we then classify patients by the basis of a history, and then we use that history as a paradigm to define disease, particularly in the context of recurrent miscarriage, and that this doesn't actually work for any well. You've just had a fantastic conference hearing the most unbelievable advances of science. The change in this field is just fantastic. And now is the time to not use history to say what's wrong with a patient and to use the advances in genetics. So in NHS, we have diagnosis of recurrent miscarriage, unexplained, and we have unexplained infertility. Hopefully we can do better than that. So you've seen this iceberg before from my previous speaker. So what is the problem? What is the problem with patients who present to us who badly want a baby? So we know that from about, if you start with around 100 embryos, about 30 are lost in a pre-implantation stage, another 30 will be lost preclinically, 10 will present as clinical miscarriages, so some evidence of pregnancy on ultrasound scan, and the pregnancy is then lost, and only 30 end up with live birth. So what's happening during this massive pregnancy loss iceberg? Well, what's happening is a genetic selection. And at each stage, we'd argue that the pregnancy gets more and more normal, and that by the time you get to live birth, we have a large number of normal pregnancies. And of course, we've got a lot of evidence for this. We know that in very early embryos, there's a lot of mosaicism. There's more euploid embryos by the time you get to cleavage stage embryos, and by the time you get to blastocyst, there's more euploid embryos. So you go from a very high number of abnormalities to 17% euploid to 42% euploid. So one of the things that's happening through this iceberg is an increasing number of normal embryos. How do we see recurrent miscarriage? So how we see recurrent miscarriage is like this. If you're on your second or third miscarriage, in fact, the most likely cause of that miscarriage is straightforward. It's an abnormal fetal karyotype. And there's only a small chance that you lost a normal pregnancy. However, remember, my problem is we define disease by counting. If we count the number of miscarriages and you're on your 6th or 7th miscarriage, in fact, you're more likely to be losing normal or abnormal. So this is the way we think about recurrent miscarriage. The problem clearly with this is it's based on counting the number of miscarriages in order to determine whether the patient's losing normal or abnormal miscarriages. What is the result of using a history or using that number of miscarriages as defining a disease? Well, the result of using that is things like this. So this is a very large NHS-funded trial that was done in the UK and also in Netherlands. This was a huge amount of work involving in the region of 60 centres, and lots of people spent a huge amount of time randomising patients with recurrent miscarriage to progesterone or placebo between 5 and 7 weeks gestation. Now, the idea of this trial is that we'd recruit so many people that we would be able to show some sort of benefit, or we would power the trial to show that progesterone benefits. And look at the graph. We were all absolutely devastated. This was years in the planning. It cost £2 million of NHS money, which is the NHS who doesn't have any money, and look what we found. We were completely devastated. And then I'm sure if the rest of the people who come from Europe and North America think, oh, that's ridiculous. Of course progesterone works. The whole British recurrent miscarriage establishment has just come up with this. Now, how did this happen? Well, the final author, my colleague, Professor Kumarasamy, then looked at the data in more detail. And look what he found, that in fact, if you'd actually lost, there was a sort of dose-response effect, and the more miscarriages you've lost, the more likely progesterone was to work. And in fact, in the Cochrane that's just been published very recently, again, this idea of that if you've only lost 2 miscarriages, there's no evidence that progesterone works, but if you've lost 3 or more miscarriages, there is some evidence that progesterone works. So look, it's look at the fantastic science you've used, and the poor old miscarriage people, oh my goodness, we're going to count the number of miscarriages to find out if progesterone works. It doesn't work clinically, does it? You can't say to the patient, oh, well, you're only on your 3rd miscarriage, I'll give you progesterone on your 5th miscarriage. I mean, this is what we're talking about in the UK. Please help us. This is UK NHS progesterone's too expensive for the NHS. You have to be on your 5th loss before you can have it. Come on, we've got to do better than this. What's the other thing? We've always known for ages, haven't we? This is deliberately a very old study, slide, that the older you are, the more likely you are to miscarry and the less fertile you are. So what we were trying to do is to try and have a way of thinking about miscarriage in terms of decidual selection. And this comes from, again, the old concept that we all know very well, that most karyotypically normal pregnancies continue and most abnormal pregnancies miscarry. We know that the human endometrium is really fantastic at selection, and we know that from data from people who present to us with recurrent miscarriage and balanced translocations. So if you're a recurrent miscarriage and have a balanced translocation, 50% of your gametes should be unbalanced, so 50% of your miscarriages should be of unbalanced translocations. But what happens in nature? Well, nature's incredible, isn't it? So the best study is from the Netherlands, where they got everybody who had recurrent miscarriage and balanced translocation over 10 years. So they got 550 pregnancies of people with recurrent miscarriage and a balanced translocation, and only 1 infant was born with an unbalanced translocation. I mean, this is unbelievably good selection. So we know that decidual selects pregnancies really, really well. Nature's wonderful, that's good, that's cheap. We don't have to do anything in my cost-neutral NHS. It's our favourite word in the NHS, cost-neutral. I still don't exactly know what that means, but anyway. So we then decided that in the recurrent miscarriage world, that maybe the cause of recurrent miscarriage was superfertility. So the idea with superfertility, there was a change in this pregnancy loss iceberg. And in fact, you weren't as good as selecting as someone who didn't have recurrent miscarriage. And if you're not as good as selecting, then some of the pregnancies that are lost before the time of the period, so in the pre-implant, the very early pregnancy loss, so they're lost before, they present clinically as a period, actually stick around a bit longer. Your endometrium's a bit more receptive, and it sticks around a bit longer, so you present clinically as a miscarriage. So we then have this, we then got a lot of work and a lot of papers where we've worked very hard to understand how the endometrium selects normal and abnormal embryos. So we've now got a situation where you have a lot of mosaicism that then occurs less frequently in blastocysts. This embryo then sits on the endometrium. There's some sort of biosensing. And then in a normal patient, the abnormal ones are a period. In the normal ones carry on. In a recurrent miscarriage patient, the abnormal ones stick there a bit longer, present to you as a doctor as a period, present to you as a doctor as a miscarriage. So the whole process and the whole cause of recurrent miscarriage is failure of embryo selection, and we think that the way that the endometrium is able to select pregnancies is by this process of decidualisation. So decidualisation is the change in the endometrium that occurs both pre-implantation and during very early pregnancy, and it's a progesterone-driven phenomenon. It involves massive changes in stromal cells. It also involves changes in your glands and your immunocompetent cells and leukocytes. So my problem with these theories that's talked about a lot of conferences is we haven't really got anywhere with treatment. Because if all that was very true, we should be able to easily improve selectivity, and there is an easy way to do it because we know that decidualisation is driven by progesterone. We should easily be able to give progesterone, improve decidualisation, and prevent miscarriage. We haven't managed to do that. If you compare that with the first speaker in this session, Professor Simon, he's able to give progesterone and improve his success rate. We haven't managed that in miscarriage. So what else is the obvious corollary from these theories? So if all this is right, then if you put a normal embryo back in someone who's simply got super receptive endometrium, then she should have a baby. And now all your guys are very capable of doing that. So the problem is that, in fact, the studies, or the published cohort studies in this area, quite frankly, I'm very disappointed. So here's a very good study from Japan. So it's not a randomized trial. As you can imagine, randomizing these patients would be extremely difficult. So this is a patient preference cohort study. And there they've looked at people with recurrent miscarriage, balanced translocations, and done pre-gestation diagnosis. And in terms of the number of women who ended up with a baby, there was no difference whether you did that or just let them try on their own. And also the time between you saw them in clinic and they ended up with a baby was no difference. I mean, that is really, really disappointing. The people who had PGD had a few less miscarriages. But really, really, that is disappointing. There wasn't a huge difference in the number of people who ended up with a baby or the time between you being seen in clinic and ending up with a baby. Again, there's another patient preference cohort study published from the States. Again, they've used recurrent miscarriage and pre-gestation screening. Again, it's disappointing. If all our theories are right, if you put the normal embryo back, there should be a much better clinical outcome. But again, they've said no difference in the live birth rate in terms of the number of women ending up with a baby, and no difference in the time to having a baby. So my problem is why is everything so, we have these fantastic theories, we've got this fantastic science, we've got these fantastic solutions. Why is the care of my recurrent patient miscarriage cases not really getting any better after all this work and all these years? So I've had a look at so I'm going to show you some data from my recurrent miscarriage clinic. So what happens in my recurrent miscarriage clinic is if you miscarry, we take your miscarried tissue and we send it to the regional genetics laboratory, who use the same techniques they would use if you sent them a coronary venous sampling for prenatal diagnosis. They use quantitative fluorescent PCR, array CGH and MLP in order to get the best result they can from the sample. Now, so we've got 145 miscarriages from 125 women. Only 101 samples were suitable for analysis. Now, the reason for that is not what you expect. I went to lots of conferences and I thought if we did surgical management of miscarriage, we'd get lots of results. But in fact, in the NHS, unfortunately, we do general anaesthetic surgical management of miscarriage, and we use extremely powerful suction machine, which is very quick, because we haven't got much time, because time costs money, and it destroys the tissue to such an extent that when it gets to the genetics lab, they can't even tell what's trophoblast. So in the NHS, this probably doesn't apply to you, in the NHS, the best way to get a result is medical management of miscarriage. I think if you use outpatient MUA, that would also be excellent. So in my miscarriage clinic, I have a tertiary referral centre. I see the worst cases from all over the UK. 45% of them had abnormal karyotype, and 4 had balanced translocations. So this 45% is very similar to all the other published studies. So with recurrent miscarriage, it doesn't matter if you used old-fashioned culture or whether you're in the NHS or Chicago or in Japan. It's very similar, high number of karyotypic abnormalities in recurrent miscarriage. And everybody else says, well, of course, the older the women, the more abnormalities you get, the more miscarriages you had before, the lower the abnormality rate. And actually having an abnormal embryo is really good, because an abnormal embryo is a sporadic one-off event, and it's fine because that means you're going to be, next time, by chance, if you get a normal embryo, you're going to be fine. So they thought, oh, well, that's what's happening with my patients. So here's the list of trisomies again, similar to everybody else. But unfortunately, on my patients, the same thing didn't happen. So if you look at the age graph, I had a lot of people who are in the older age group who are losing normal pregnancies. The reason this is important, because in the NHS, some doctors think you shouldn't even investigate an older person because they're only having abnormal pregnancies. There's no point looking for the result. I mean, this is awful. You know, even if you're seeing a patient who's 40 and having recurrent miscarriage, sometimes she's losing normal embryos. It's really, really clear. The other thing that happened in my clinic is we assume that people who are losing sort of 10 or more pregnancies must be losing normal ones. No, that's not true. Some of those are losing abnormal ones. So what on earth is going on? Well, I thought, well, everybody else says if you have an abnormal pregnancy, and then it predicts your future pregnancy will be normal. Did that happen in my clinic? No. So here's my logistic regression analysis, and previous live birth, number of miscarriages, age, all predicted a future live birth, but previous karyotype didn't. So why was that? And this is my shocking point. I had 8 women who had the loss of a euploid pregnancy, who then lost another euploid pregnancy. I had 9 women who lost an aneuploid pregnancy, who then lost another aneuploid pregnancy. These didn't have balanced translocations. And 1 woman who had normal, abnormal. Oh my goodness, it seems that there's 2 groups of people. One group of people who recurrently lose normal pregnancies, and a second group who recurrently lose abnormal pregnancies. So, is there evidence in the literature for this group of people who recurrently lose abnormal pregnancies? Well, I'm going to argue yes. So here's a very large study of people who've used PGS for looking at embryos coming from patients with previous implantation failure and previous recurrent pregnancy loss. And in the recurrent pregnancy loss, there was an increased number of abnormalities in the blastocyst. Again, in another paper from Japan, they did a very similar study from me. So here, we've got 32 women who had 2 abnormal losses in a row, 38 women who had 2 normal losses in a row, and only 25 mixed. That's very similar to my findings. Now, they've said, oh, if you keep losing abnormal pregnancies, you're a good patient because you end up with a cumulative 71% live birth rate. And if you keep losing normal pregnancies, you're a bad patient because you end up with a 44% live birth rate. But actually, for someone who's trying for a baby over several years, a 70% live birth rate is not that good, because remember, nearly 30% of them will have not had what they wanted, which is a babe, ended up with the live birth they badly wanted in an era when we've got so much technology available. So what more evidence have I got for this concept of some people recurrently losing normal pregnancies and some people recurrently having aneuploidy? Well, one of the lines of evidence is one of the this is from one of the studies that I found disappointing in that it didn't show a massive improvement in live birth weight with PGS. One of the reasons is some of the people had recurrently, they weren't able to weren't able to transfer the embryos, and that was because of a high failure. And that group of people have a high miscarriage rate. So here's some more evidence to support this concept of recurrent abnormal pregnancies or recurrent aneuploidy in a certain group of people. Here, if you look at the last, the bottom table, recurrent miscarriage, you have a much higher odds ratio of having an aneuploid embryo than if you have male factor infertility. So, is it possible that some of our patients, in fact, have got something wrong with them that means they have recurrent aneuploidy, which is different from someone who has recurrent normal pregnancies? This is a really key distinction, because obviously this group of people are going to need completely different treatment. There has been published a mouse model of chromosome mosaicism, so a mouse model where the mice make lots of mosaic embryos similar to that we see in humans. And there they've suggested that there's a mechanism where this can be corrected. So if there's a mechanism where this is being corrected in nature, that to me means that it's the possibility it goes wrong in other people. One more additional complexity to all this is the work that's been done over many years by Thomas Philippe. So he, when someone miscarries, does an embryoscopy, so puts a hysteroscope into the uterus, looks to see how structurally normal or abnormal the embryo is. And he's again reminded us that some of the embryos that have, or some of the miscarriages that are karyotypically normal, actually have gross structural abnormalities. So there's another cause of structural abnormalities that we don't always get the reason for. So what I'm trying to say to you is that miscarriage needs to be defined using the technology. It's all very well using all your fantastic technology for treatment and having your fantastic PGS and PGA and the amazing things we can do, but please use that as a diagnosis, because if we give the right treatment to the right patients, then I'm sure that we both have the most efficient health service with the least trauma to the patient and the best outcomes. So now, miscarriage should either be a sporadic loss, a one-off loss of an aneuploidy baby, aneuploid pregnancy, or you've got recurrent pregnancy loss, recurrent loss of a normal pregnancy. If you've got recurrent loss of the normal pregnancy, you must have an underlying disorder. We've got evidence that if you've got recurrent loss of normal pregnancy, that progesterone prevents it. Clearly, the rest of the world use progesterone, so that we need to find new cures for people who recurrently lose normal pregnancies. If you recurrently lose normal pregnancies, putting a normal embryo back isn't going to make any difference. You need to fix the problem. There's another group of people who recurrently lose abnormal pregnancies. These are the ones that need PGS. Are there a group of people who never make a normal pregnancy? We don't know. So in conclusion, the point of my talk today is to say, if someone miscarries in your care, however they get pregnant, it's essential they get karyotyped with the best technology you have available to you in your healthcare system. The idea that recurrent miscarriage is a disease is outdated. We've got far better technology available, even in a cash-poor NHS. We need to change this concept to loss of a euploid pregnancy or loss of an abnormal pregnancy, and then have a different management regime for each thing. So thank you very much for listening to me, and here's my acknowledgements.